first of all, I'd like to thank Dr. Santosh Honavar for giving me this opportunity. My topic was allotted Uvea X5. So what I'll do, I'll just go through some cases, and before that, because it's a program for the postgraduate, so I would request the postgraduates, if you have any query or if it remains unanswered, or you are watching this program, the recording of this program, then you feel free to mail me at Dr.Parthopratim@gmail.com. I'll be very happy to answer your query. So what I'll do, I'll show 6 case scenarios and we'll discuss the learning points from these case scenarios. Now, first I'll present 2 cases. One is 40-year-old male and the second one is 28-year-old female. The first patient, 40-year-old male, presented with minimal blurring of vision for 3 to 4 months, and there was no complaint of redness and ocular pain. The second patient had severe ocular pain, redness, intolerance to bright light, and the patient came to our clinic almost in a very acute stage. And for last 2 days, she was receiving this kind of severe pain and redness. So when we examined, we found that the right eye has the other eye is having a cells of 0.5 and flare and no KPs. Whereas the second case, it was unilateral, the other eye was quiet. Now, if you look into their symptoms, you can see that the first patient had a chronic course and it is insidious onset. Now, insidious onset is what? When a disease comes slowly and does not have any obvious symptom, then we call it as a insidious onset. In the second patient, it has an acute course and there was a sudden onset disease. Only for last 2 days, the patient was having severe pain. Now, if you look into the clinical photograph here, slit lamp photograph here, you can actually see the mutton fat KPs, absence of congestion, and you can see some iris nodules also. Whereas in the second patient, you can see the fine KPs, there are marked congestion and there is no iris nodules. So based on that, you can easily differentiate them into the first patient is a case of granulomatous uveitis and the second one is non-granulomatous uveitis. So there are many causes of them and I'm sure you know them. So what happened, we went ahead and investigated the patient. The first patient, the serum AC was raised, want-to test was negative, and HRCT showed mediastinal lymphadenopathy. So the first patient was diagnosed as a case of sarcoidosis, and the second patient, HLA-B27 was positive and started on treatment. So this is very important point. You have to understand that beginning is the most important part of any work. And when you are starting your work, Uvea work, try to use this Woods or clinico-pathological classification, because this classification gives you a very good overview and provides an approach to the initial workup. Whereas the downside of this classification is it's not very definitive. You can't use granulomatous, non-granulomatous, because sometimes there will be overlapping of the clinical entities and they may change their clinical phenotype also. The third patient was 27-year-old female who presented with diminution of vision, no complaint of redness or ocular pain. However, she informed us about the elevated T3 and T4. So now if you look carefully, you can see the right eye is quite AC. Sorry, right eye was the quite anterior chamber, and the left eye, there was cells of 0.5 and there was flare. And there was diffuse distribution of KPs. As you can see here, fundus examination was within normal limit. So further, if you can examine the patient, you can make out that the blurring of iris crypts, especially at the polarity, there was absence of synechia, there was cataract in this patient, and a diffuse distribution of the KPs. Now, unilateral anterior uveitis differential diagnoses are HLA-B27 associated, Fuchs uveitis, and viral anterior uveitis. In this patient, we can easily rule out HLA-B27 because it has an acute presentation, as I already said, and there are actually recurrent in nature and they keeps alternating between the eyes. The Fuchs uveitis and viral anterior uveitis are usually confined to the single eye, but as you can make out in this patient, there was a subtle changes in the iris pattern and there was a diffuse KPs, and if you look carefully, these are actually the stellate KPs, And so that's how you can make out that this was a case of Fuchs uveitis. Whereas in viral anterior uveitis, you have to look for the iris atrophy and various other signs, like the patient will have a corneal scar. So these points can lead you to the diagnosis of the viral uveitis in a patient. So our fourth case is a 37-year-old male who complained of diminution of vision, redness, ocular pain for 15 days. The best corrected visual acuity in right eye was 6/6, left eye it was 6/36. There was history of encephalitis in 2012 when the PCR from cerebrospinal fluid was positive for the herpes simplex virus. Following that, he developed certain amount of cognitive and short-term memory loss. And when he presented to us, the right eye AC was quiet, left eye had cells of 3+ and clear 1+. Now, as you can see here, the right eye was within normal limit. The left eye, there was hyperemic disc, vitreitis. You can see some areas of arteritis here also. So when we started examining the periphery, we realized the picture was different. As you can see here, right eye, there was 2 patches here of healed lesion, and here you can see the confluent lesion which was progressing actually almost in 360 degree, and you can see the arteritis patches here. So it was a case of retinitis, and retinitis involving the periphery of the retina. So he was diagnosed as a case of acute retinal necrosis. Right eye was probably the healed retinitis. So what we did, we started the patient on intravenous acyclovir. AC tap was done for HSV, VZV, and CMV, which was positive for herpes simplex viruses. And the patient was continued on acyclovir, and the patient was monitored weekly basis. Every week, I used to call the patient and see the patient. Now, after 3 months, as you can see here, the lesion regressed very, very nicely. You can see here the regressed retinitis patches, and the patient was continued on the acyclovir for a certain period of time. So now, what are the learning points from this case? The dilated fundus examination is must, as you have seen. If I would not have examined the patient. So next time you see a uveitis patient, examine the periphery very carefully. And the next, the higher chances of the developing RDs are there. So that's why the patient was actually monitored weekly basis. Now, why AC tap? I'm showing you another picture here. As you can see here, this patient actually, when we did the AC tap, and it was positive for CMV cytomegaloviruses. Now, you have to remember that if it is caused by cytomegalovirus, acyclovir is not active in these cases, because acyclovir need thymidine kinase to work, and the cytomegalovirus does not contain this thymidine kinase. So you need to do AC tap in cases of acute retinal necrosis. Here is the 5th case, which presented with severe diminution of vision in both eyes with cells of variable degree, cells and flare. And you can see that there are large capes, mutton fat capes also in one eye. So this was the picture we presented with pockets of subretinal fluid and choroidal fluids. So what are your differential diagnoses? In this scenario, pan-uveitis, you can think of mainly 3 conditions. One is posterior scleritis, one is Vogt-Koyanagi-Harada disease, and the third one is your posterior scleritis and sympathetic ophthalmia. I forgot to tell you, this patient also had the severe headache and disturbances in hearing also. So now your diagnosis has become much easier. So what all investigation we did? We did ultrasound B scan, which showed low to medium reflective thickening of the choroid. And here is a clue I would like to share with you, that how to differentiate the VKH and posterior scleritis in ultrasound. Though it is very difficult in ultrasound, but you have to keep, you have to remember that the VKH sclera is secondarily involved, whereas in posterior scleritis, it is the primary structure to be involved. So that's why the sclera has a high reflectivity. When you compare both the entity, the posterior scleritis has significantly higher reflectivity of the sclera, and sometimes you can see the retrovalvular edema, which causing the T sites. Now, if you look into this patient's SSOCT, you can see that it has a multilobular configuration. When we call it multilobular configuration, we mean that the subretinal fluid is organized into multiple compartments. Now, how these compartments are formed? These are formed by the inflammation-induced some fibrinous septa. Now, look into the FFA picture, you can make out that why it is multiple compartment. You see here, these are the multiple leaks here, pinhead leaks, which are actually showing the placoid pooling. So these are the areas, the multiple compartment, the dyes are accumulating and showing the placoid pooling of the disc. Now, what are the learning point from this point? So this FFA picture, is it very specific to Vicage? No, it can be seen in multiple conditions. It can be seen in posterior scleritis, it can be sympathetic ophthalmia. Now, one of you may ask me that then why to order FFA in Vicage? For that, I will show you another case. This is a 27-year female complained of diminution of vision, and incidentally, as you see in your clinical practice, any patient can complain of headache. So this patient also complained of some non-specific headache. So the patient was diagnosed as Vicage, started on oral prednisolone 60 mg per day. And when the patient actually reached our chamber and we did the fundus fluorescent angiography, you can see here, the fundus fluorescent angiography looked a little different. There was multiple leak here also, but this leak did not show placoid pooling. It increased in size and intensity. Can you make out from here? See here, these are increasing in size and intensity. So it was a case of multiple leak CSR. So next time you see, you can see these two cases. The first case is CSR, multiple leak CSR, and the second is Vicage, where you can see placoid pooling, and here you can see the multiple leak increasing in size and intensity. So what happens under the right circumstances, these pictures can be, clinical pictures can be similar until and unless if you do FFA, the serious consequences occur. In CSR, you have to stop the steroid, whereas in Vicage, steroid is the primary treatment. Now, quickly, how to treat that particular case? You have a lot of form of steroid. What steroid you will give here? You will give pulse corticosteroid because it is sight-threatening condition, followed by oral corticosteroid and immunosuppressive. Now, why immunosuppressive will give? Because Vicage causes recurrent inflammation. To prevent that recurrence, you need to give immunosuppressive. Now, any role of intravitreal steroid? Very limited and in special situation. Because Vicage is a systemic disease, you have to treat the disease systemically. So when to use intravitreal steroid? For example, when a patient is pregnant, can't tolerate the high dose of steroid, that time you can think of these entities. The last concluding point is always take reliable history, comprehensive eye examination, identify the anatomical location and extent of the inflammation, and try to do systemic evaluation. This is the last case I am going to show you, a 32-year-old male with Hypopyon Uveitis. Now there can be three pictures, three clinical scenarios the patient with Hypopyon can present to your OPD. The first one can have the non-granulomatous uveitis. Already we discussed severe fibrinous reaction, low backache, and complaints of recurrent attacks. So what you will do? You will advise HLA-B27 and X-ray of the sacroiliac joint. And this can be a case of, as you can make out, it was a HLA-B27. The second one, panuveitis, can have retinal vasculitis, mobile hypopyon, and recurrent oral and genital ulcers. So in this case, you can simply do some tests, send to rheumatologist and make a diagnosis of Behçet disease. The third one, it can present as a panuveitis, can give you a history of hospitalization, can give a systemic association like diabetes mellitus, and can give you a history of septic foci also. So in that case, you have to do a vitreous biopsy, send the blood and urine for culture, and clearly it was a case, it will be a case of endogenous endophthalmitis. Thank you for your hearing.
Thank you, Dr. Partho, for elegant description and giving some learning points from the several cases. I'm glad that you have highlighted non-uveitic conditions which can mimic uveitis and is very important, like Masquerade syndrome, multiple leak CSR. And distinguishing from non-granulomatous to granulomatous uveitis is important because the investigation pattern is different. And also the cases like, Hypopyon in several situations, one need to distinguish the same. So thank you very much all. And thank you, Dr. Honabar, for giving me this opportunity to chairing the session on the